everyone. Myself Dr. Priyanka, and I'm one of your mentors for study MRCPI. So, for MRCPI Part 2 written, today we'll be discussing an important topic for the exam, that is the chicken pox in pregnancy. So, we are having the Triple A series, so where we will be discussing important topics related to the exam. So, do like, share, and subscribe to StudyMEDIC channel, and also press the bell button icon to get the updates on recently added videos. Thank you so much. So coming to chicken pox, so as we know, it belongs to the family of the varicella zoster virus, and it is a double-stranded DNA virus, and it comes under the family of herpes, and also it is considered as highly contagious because it spreads by the droplet route and through the respiratory airways. So it is considered as highly infectious, and but most of the women mostly from the tropical areas, almost 90% of the population is immune to chicken pox because of the infection they had in the childhood. So most of them will be like immune, but as we know that chicken pox can have teratogenic effects on the fetus. So proper management of this pregnancy is very important. So when is the incubation period? So the incubation period is from 14 to 16 days after the exposure to a varicella patient. And the rash, the person is considered as very contagious, that is the infectious when there is the beginning of rash at least 1 to 2 days before the rash onset, and up until the vesicles has crusted over. So that is the most infectious period where the patient should be isolated from other patients, especially the immunocompromised population like elderly or children or pregnant patients. And regarding varicella vaccination, so we know that it is a live attenuated vaccine, and hence it is usually it is contraindicated in pregnancy. And whenever before pregnancy, if it is given, the vaccine is given, then according to the pediatric guidelines, so at least 1 month of gap should be there after the vaccination and planning the pregnancy, because there is theoretical risk of having the infection because of it is a live attenuated vaccine. And also it can, in the postnatal period, this vaccine can be given. There are 2 doses which are taken 4 weeks apart. So this can be given in the postnatal period. It is safe to give. Regarding the rash. So if there is an history, if the woman comes with the history of onset, if the history of exposure to a chicken pox, a patient who has chicken pox, so she should be asked regarding her immunity if she had any history of chicken pox in the childhood. And if she did not have any doesn't give any history, or if the immunoglobulin G, the varicella immunoglobulin G is less than 100, then she should be told to monitor for the onset of symptoms of chicken pox for at least 3 to 4 weeks. And that is the rash. So, and she should be considered potentially infectious, and from day 8 to 21 days post exposure, if she doesn't receive any treatment, or if she receives a cyclovir, or from day 8 to 28 days if she receives immunoglobulin G, varicella immunoglobulin. So for those who are at high risk of developing severe chicken pox, like those who are having medical conditions, like especially asthma, or those who are on immunosuppressive medications, or those who have certain risk factors, like they are smokers who are at high risk of having chicken pox, severe varicella infection. So they should be asked to monitor the symptoms vigilantly, and to inform if they have or any problem, any deteriorating condition. And also those with sepsis, that is the one who has organ dysfunction with suspected infection, so they should be monitored in the or they should be admitted in the high dependency or a intensive care unit. And also for the staff, like the hospital staff who are caring for the woman, should also be immune to the varicella, either by a natural immunity, by having the infection in the past, or by they should receive 2 doses of varicella vaccine. So for those women who have severe chicken pox, severe in the sense that they are having organ dysfunction, like in the form of chicken pox, pneumonia, or encephalitis, or hepatitis, so they should be admitted in the SU or an ICU, and they should receive not oral but IV cyclovir at any period of gestation. That is the recommendation by the Irish guideline. And the dose of IV cyclovir is 10 milligram per kilogram 3 times a day. It is every 8 hourly. And because we are giving IV acyclovir, so if they are receiving any other nephrotoxic medications, so for their renal function should be monitored. The urea and creatinine should be monitored. So regarding the fetal effects, so we know that the risk of fetal varicella, especially is more if it is happens in the first trimester and especially between 13 to 20 weeks. So whenever the patient is shows any symptoms of varicella and is found to have chicken pox, so she should be referred to the fetal medicine specialist at almost 16 to 20 weeks of gestation, or from 5 weeks after the infection. Like 5 weeks should be there for the fetal effects to happen. So after 5 weeks, they should be referred to the fetal medicine specialist for an ultrasound. And to know the infection in the fetus, check for the DNA polymerase, the varicella DNA. If it is if at all it is required, that should be weighed upon. And the amniocentesis, the risk and benefits should be explained to the patient, because if there are active lesions and an amniocentesis is done, so that will carry the risk of infection to the fetus. So this all should be explained, and preferably the amniocentesis should be performed whenever the lesions have been healed, and after that, or at least 5 weeks after the infection, the amniocentesis can be performed. And the highest risk of developing the primary varicella infection, the disseminated varicella in the neonate, is when the mother develops infection in the last 4 weeks of the delivery. So this all should be explained to the patient. So what all can be the effects of congenital varicella infection? So there can be multiple organs which are affected in case of congenital effects of chickenpox. So there can be skin lesions, that is in the form of scarring, or there can be limb hypoplasia, as you can see in this neonate, or there can be neurological abnormalities in the form of microcephaly or cortical atrophy or hydrocephaly, mental retardation. There can be eye disorders like microphthalmia, chorioretinitis, cataracts, and muscle hypoplasia. And on long term, there studies are insufficient, but still there is a link that it can cause long term learning difficulties and developmental problems in the future. So how they should be monitored in the intrapartum period? So they should be especially delivered in a consultant-led unit, especially those who are having severe chicken pox. And the planned delivery for 7 days should be avoided, because the maternal antibodies, they take at least 7 days to transfer from the mother to the fetus, so that the fetus is protected. So planned delivery at least within 6 days, within 7 days should be avoided to so that it won't pose the risk to the fetus. And during the time of delivery, the neonatologist should be there at the time of birth. And the mode of delivery is a vaginal, until and unless there are any obstetric indications for having a cesarean section. And while planning a cesarean, or if the patient is on epidural, then the site should be free of the vesicles. So regarding breastfeeding, so yes, acyclovir can be given in the during the breastfeeding period, and it does pass in the breast milk, but the guidelines says that it does not cause any effects on the neonate, and that can be given. But also regarding the vesicles, so if there are active lesions present on the breast, for example, on the affected breast, so then the recommendation is to is the woman should be encouraged to express the milk from the affected breast where there are lesions, and then she can feed the baby. Not to feed from the breast where there are active lesions present, and not to breastfeed, like nipple feed the baby. So they can express the milk and feed, and until the lesions, once the lesions have crusted over, it is safe to breastfeed properly. So this is the algorithm for the management of the chicken pox in pregnancy. So once the woman comes with a history of contact with a person who has symptoms of chicken pox, like, so we should ask first how significant is the exposure. So significance is if they are in the same room for 15 minutes or more, or if there is a face-to-face contact which is more than 5 minutes. So that should be asked. And her immunity should be asked, that if she had any history of childhood chicken pox, or has she received any 2 doses of the varicella vaccine, Varivax. So if she received 2 doses of varicella vaccine, or if she has had chicken pox, so then we can assume that she had the infection, because that is the uh, uh, once she has a chicken pox, so that will be having a lifelong immunity, so she won't need any post exposure prophylaxis. Or if she's uncertain, in cases, certain cases, if she's uncertain that she had chicken pox or not, or if she has received any varicella vaccine or not, then we can do a antenatal booking bloods. We can check that for varicella immunoglobulin G. So depending upon the levels of immunoglobulin G, if there are more than 100 milli international units per ml, we can assume that she has a past infection, or she has received already passive immunity, and there is no need for the post exposure prophylaxis. But if the values are of the immunoglobulin G are less than 100, then she is considered as non-immune for chickenpox, and then she should be given the acyclovir, which is the newest recommendation. So that is recommended. The oral acyclovir is given 800 mg 4 times per day for 7 days, and the course is started on day 7. It is started, but it can be started up to day 14. That is the recommendation. And if the woman is not does not want acyclovir, or if she is allergic to acyclovir, then the second option is giving varicella immunoglobulin. So that can be given up to 10 days of the exposure. And as I said, that they need to be considered infectious. If they receive immunoglobulin, they should be considered infectious from day 8 to 28. Or if they receive acyclovir or no prophylaxis, then they should be considered infectious from day 8 to day 21. Okay. So regarding the varicella zoster immunoglobulin, so in neonates, so here the management depends upon who has the chickenpox. So is the mother who has the chickenpox, is the mother index case. So if mother is the index case, then we need to ask, because preferably the delivery is avoided within 7 days. So that needs to be asked, that when was the rash onset in the mother. And if it was less than 7 days before, or the birth happened within 7 days after the onset of rash, then the neonate needs to be given varicella immunoglobulin. But if there is no history of the mother being the index case, then the history of contact should be asked. So if it was less than 48 hours before the onset of the varicella or the zoster rash, then depending upon the if the neonate is term or preterm, the management will be. So if the neonate is preterm, the baby should receive immunoglobulin, and it will be a specialist care. The baby should be referred to a specialist care. And if it is the baby full term, and if the delivery has happened less than 7 days, it depends upon the maternal immune status. So if the mother has immunoglobulin G antibody positive, then means that she is immune, and the baby doesn't need any immunoglobulin, varicella immunoglobulin. But if the mother has varicella antibody negative, means that she is susceptible, then in that case the neonate is given varicella immunoglobulin if it is less than 10 days of exposure. So here in chickenpox, a most important thing is that there are fetal effects which can happen in chickenpox. The fetal varicella syndrome up to 28 weeks, the risk is almost up to 1%. And elective delivery should be avoided for almost up to within 7 days to allow the passive transfer of the antibodies from the mother to the fetus. And they can have vaginal delivery. There is no indication to have a cesarean section for the sole purpose of chickenpox. Also, to know the fetal effects, they should have they should be referred to the fetal medicine specialist between 16 to 20 weeks or 5 weeks after the infection. And the first line of management is the oral acyclovir, which is given 800 mg 4 times per day for 7 days. And the second line is immunoglobulin, the varicella immunoglobulin. And in severe cases, like the one who, that's why the history taking is most important, to know the risk factors in the patient, like do they smoke, take alcohol, or do they have any other medical comorbidities like asthma or COPD, which can increase the risk of severe chickenpox in them. And hence they will need a further HDU or ICU care. So that all needs to be asked, and they will require an IV acyclovir dose of 10 milligram per kg. That is given 3 times per day. So that is all about the chicken pox. I hope this helps. Thank you so much.